in the acute care setting, why do you think that we might use that particular setting out and talk about it in more detail than we might some of the other settings where we might need or encounter babies? Exactly. It truly is one of those situations where the ability to communicate can be life or death. Where do you think the most likely part or department in the hospital to encounter ADC?
ICU.
ICU is number one. What do you think number two?
Rehab. Rehab.
Rehab is number two. And what about number three? Emergency department. Why ICU? Why do you think we have such an urgent and prolific need for it?
Because a lot of time people might have like trachs and they can't speak.
Intubation is probably the biggest reason why a person's not going to be talking. And like Jess said, it's more often because they may have a trach as well, they may be on a ventilator, so they can't make sound. And oftentimes in that particular setting, there's essential communication that needs to take place. I was just checking my email before I came up and happened to notice there was a story about a guy up in Indianapolis who was involved in an accident, fell, and was basically completely paralyzed and on a ventilator, and his neck wasn't even stable enough for him to do like head nods or head shakes or anything. Obviously, I mean, you've broken it was the C2, 3, and 4 vertebrae in your neck. You're not going to be moving your neck very much. But he was asked, his family had to ask him what did he want to do. And so, I mean, there are critical pieces of communication that need to be able to take place in that setting, including literally life or death. Do you want to stay hooked up to this machine? They're saying that you're never going to breathe on your own again, or, so it can be critical. So that's why we're going to talk about it. And the acute care, and particularly the ICU, the type of communication systems that we are going to use are often quite different than what we'd be using for someone, say, like Leanna. Why is that? Why are we typically not going to be seeing a lot of devices, high tech, in the hospital or in the ICU?
Because it's just very short term. See something quick and cheap.
Okay, it can be cumbersome. We need something typically quicker. What else?
I might not be able to be trained on whatever it is.
And usually the need is going to be temporary. So we don't want to be spending thousands of dollars on some expensive system for someone, not even hundreds of dollars like, a tablet, because it's usually temporary. Okay, so let's talk about AACs in the future. As I said, read the red. It can be a life and death. And at the very end, I'm going to tell you where it actually was life and death. AAC in the ICU, particularly with trach patients, can take a somewhat different form than anything we've talked about. Up to now we've talked about picture books, communication boards, tablets, high-tech, low-tech types of devices. There's another device that we haven't talked about, and that's the speaking trach valve. And there are some who say, oh, that's not AAC. There are others that say yes, very legitimately it is. I tend to be one that says yes, because it's a device that is used to help the person generate speech when they ordinarily could not. But there are others that follow the ASHA definition of AAC very strictly, and it says that it's communication through some method other than oral. Well, the person's nonverbal, but you can give them a device that allows them to be verbal. Is that not what we're doing with a computer system like Leanna has, where we're giving them a voice? Well, in her case, it's a computer-generated voice. It's not her own voice. Well, with a talking trach valve, we're giving the person their own voice back, but we're still taking someone who was nonverbal. So I think we're kind of splitting hairs when we do that, but regardless, we're going to talk about it here. Most often, though, we're going to need quick, simple communication, because there are often critical medical decisions that need to be made. And so the speech pathologist needs to be very knowledgeable about what's available and can put that into place, because they're going to need to talk with family members and healthcare professionals in order to play a role in being in charge of their own care. So the two main causes of an inability to verbally communicate in the medical setting are endotracheal intubation and tracheostomy, or tracheotomy. With endotracheal intubation, the person literally has a tube inserted through the mouth, down into the upper airway, through the vocal cords. So there's an actual tube. And it usually is used with mechanical ventilation. So the person actually has a machine that's changing the pressure that allows breathing, inhalation and expiration to take place. It's usually done because there's some sort of an emergency. You're not even going to be able to get the person to reliably mouth words because the articulators are restricted or blocked. And obviously you can't produce sound, there's no phonation because the vocal cords can't come together. So these folks are truly non-vocal. Trach patients, they have an opening in their neck, and they may have a ventilator, they may not, but they are breathing through this opening in their neck as opposed to through the normal upper respiratory channels, usually because there's something compromised in their upper respiratory system. But again, phonation isn't possible because here are the vocal cords up here, and here's the trach down here. So the air is coming in and out of here, and it doesn't ever make it up to vibrate the vocal cords unless it becomes occluded. Then, if they occlude the trach there, then air may, if it's fenestrated, if it's open, it may shunt upwards. If it's not, they're going to asphyxiate because now they can't breathe if they occlude. Okay? But again, they're not verbal or vocal because in their case, the airflow is completely bypassing the larynx. Okay? Does that make sense? So if I asked you a question about what's the difference between endotracheal intubation and a tracheostomy, you tell me that one involves insertion of a tube and the other involves insertion of a smaller tube directly through the nose. Okay? So when we're dealing with AAC in the medical setting, the speech pathologist is typically either the primary or the co-primary caregiver. Who do you think would be the other co-primary care team person in the acute care setting, especially in the ICU? Respiratory therapy, RT. If you are going to be a clinician in a hospital setting or any kind of a medical setting, rehab, skilled nursing, there are two people in particular that you need to get to know very well and you need to be very kind to because you will need them constantly. And that is the respiratory therapist and the dietitian. The respiratory therapist, because they're the ones that are going to teach you how to suction your patients. They're the ones that are going to teach you how to silence an alarm that's not really a big deal and can wait. They're going to teach you about which alarms, when they go off, signal you need to get help, you need to get help now. Actually, you need to get help 15 minutes ago. They're going to teach you the ins and outs. They're going to help you wean the patient from the respirator to being able to have oral intake again and to vocalize and verbally communicate. So you need to really, 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 really be good friends with them. You really need to be good friends with the pulmonologist and with the RN as well. When a person's in the ICU and they are on a ventilator or they have some sort of compromised airway, even their primary care physician who is involved is pretty much a nobody. They're always going to defer to pulmonary. And more often than not, pulmonary defers to what the respiratory therapist tells them is going on. So, in any case, you're going to have any number of specialists in terms of the physicians, the RN, and the therapies, but I would say, particularly in the ICU, it's you and respiratory. Okay? So get to know them well. They will teach you a lot. And they're good people to have on your side. We have a couple of issues with the setting. Communication is probably more vital in this setting than it is in just about any other scenario you can possibly imagine a patient being in. And their communication needs are going to really revolve around communicating with their healthcare professionals and communicating with family and friends. And they're going to be very different. They can overlap, they can be related, but the type of communication is typically very different between them. So what you have to consider is what is the person's writing ability? How well are they going to be able to gesture? What's their cognitive status? What's their reading capability? And what are their motor functions? Okay. Why? Why do we want to assess their writing capabilities?
Because if
they're able to communicate through writing.
Yeah, I mean, if they have good fine motor control and they're able to write, writing is probably the best, quickest, most natural method of communication in that ICU or in that acute care setting. And what else is really nice about written communication? It's literally a paper trail. So I will typically, when I've been called into the ICU or into a setting and I've got a patient who is unable to vocalize but has good upper extremity movement and they're able to read and write, we keep a supply of, the steno, like that steno notebook it's the notebook that kind of flips at the top. We just have a supply of those on the unit and boom, we gave it to Mr. and Mrs. Smith, whoever it was. And what's really kind of nice is once they get better, if they are going to get better and they're going to go home, it's kind of cool for them to have that to take with them as a memento. Then they can kind of see how things went, or things like it went. Doesn't make it out. They feel like they have a record of some of their final time with their loved ones, and that can be helpful. But it's great because if they're able to do it, it's natural. It leaves no doubt. Gestures, if the person maybe has some limited literacy capacities where maybe reading and writing aren't going to be as reliable, we certainly want to encourage use of gestures, so if they have the gross and fine motor skills to do that. I find, though, that gestures are somewhat limited, and you have a hard time sometimes clarifying what it is that you're trying to say through gestures in this type of a setting, because it's such specific vocabulary, sometimes specific language. The gestures may not, they're certainly not going to be adequate as the only method, but they can be something. What if your patient is in there and is intubated because they've had a traumatic brain injury? Cognition can definitely play a role. I can remember probably the most traumatic year or semester in my life. I did my master's at the University of Louisville Medical School, Dr. Scarborough as well. And we were literally in the heart of the medical school. I mean, we weren't on, I would get lost trying to find the main campus because everything was downtown and that's where we were. And, I can remember I had a dual hospital assignment. It was my spring semester of my first year. One of my assignments was to acute care, which was primarily ICU, and TCU, which is like the transitional unit from ICU to medical floor. And my other assignment was in the burn unit. And guess what happened in the spring of 1988? Any of you ever driven from here to Louisville? Around Carrollton, you see a sign, site of the fatal bus crash. Drunk driver going the wrong way hit a school bus full of people coming back from Kings Island going to Radcliffe, which is where Fort Knox is. And multiple people were killed, but multiple people were burned and had smoke inhalation. Guess where they went? They went to the University of Louisville Hospital. So, and because I was assigned to the burn, I was working with these people. And so we were working, it was primarily, at that time, up until that happened, our primary function was working on a study. There was a grant from the NIH on massage and oral motor activities to reduce scarring, and a lot of times with facial burns, when the person scars, they get banding, and so they end up with having very limited lip movement. And so we were doing a study looking at that. And this happened, and then I got thrown into AAC. And I remember one kid that I worked with who we had this dental appliance that every day we cranked it so that it stretched his lips more and more to keep them from, so he's obviously in horrific pain and he can't really talk because he's got this apparatus, and so we were trying to use writing. Initially that was hard because he had some burns on his hands. He actually lost some parts of his fingers. We were able to get to that point. And one day he was just really, really upset. And I'm obviously, all have had a burn. Well, imagine if you have burns over 90% of your body. It's very painful. But he was really upset, and I finally was able to ask him why. And he said because he actually saw himself in the mirror that day when they were changing his dressings and everything. And I had noticed that he had new dressing on his face, and I had orders to begin facial massage with him. And I was like, we had a very specific protocol, and I really didn't want to do that, particularly that day because I knew he was in a lot of pain and emotionally he was very upset. But it was good that he was able to write for me so we could help work through what was going on. And I'm not sure, I certainly don't think through gestures he would have been able to communicate to me what was going on or why he was upset. So anyway, I had another person that I was working with who was a young man, tends to be young guys, and he and his buddies had been out drinking, seniors in high school. It was May, it was getting close to graduation time. They had been out drinking, and he was an unrestrained passenger in a car versus bridge abutment accident. So at the end, like the entrance to a bridge where the guardrail turns, and his head smashed right into that. And he was intubated, and we had to wait until we had a speaking trach valve to really have a good idea of even what his cognitive function was like, because he was, if you're familiar with Rancho Amigo scale, he was recovering through it when I first started working with him. He was at level 2. That was fun too. I went away to a conference. I had seen him on Friday, went away to a conference, didn't see him again until Tuesday, and when I came back he had advanced to level 4 at Rancho Amigos, which is the confused and agitated stage. So he had actually ripped his trach out. He was a bloody mess. It was terrible. But and in his case, he was so confused and agitated that we just decided to work on coma-stimulation and do some things to try and bring him cognitively without even working on anything other than like a yes-no, just because he was so wild. So we have to consider cognition, and that can be extremely important if you're dealing with brain injury. Obviously, reading, if they're non-readers, when I was amazed, because I grew up in Cincinnati. I was a city boy my whole life. I have cousins that lived out in Indiana suburbs, but they all worked in the city and drove out there, so I mean, I wasn't being exposed to much about rural life. And then I went to grad school, Louisville, and because it's the largest city in the state, and it's where the biggest hospitals and the biggest medical school is, you get people from all over. And I I was amazed at the number of people who can't read, can't write. I would say, there were times when maybe 50% of our caseload was unable to read or write, or at least functionally. And it had nothing to do with whatever it was that brought them into the hospital. They were able to do that. So you really have to, kind of know the demographics of where you are, as to whether or not you really have to worry about that a lot. But it's surprising even in today's world how many people can't read and write. So definitely consider that. And obviously their motor skills, they're C2, 3 quadriplegic, they're not going to be able to write, folks. They basically can't hardly even, and especially early on, they're going to have a halo on. They're not going to be able to move their neck anyway. So, but certainly not anything below that level. So, high-level quads typically are going to have AAC. So, just be prepared. The RN on the unit is typically the one who is going to be your gateway to information, because they're the primary care providers in the unit, and particularly in the ICU. So you're always going to want to make sure that you touch base with the RN and read their notes about what's transpired since the last time you saw the patient. Usually I would start off when I go into the unit, I'd always just read the notes, because typically the nurses are busy actually caring for patients. So if I saw the nurse right there, I would go ahead and start asking for a quick debriefing. If I didn't see them, I'm not going to waste that time. I'm going to read the notes and then try. And then I'm going to make sure to touch base with respiratory if they're involved in the case, because they're the ones that are going to let us know, hey, I think maybe today might be the day that you want to try a speaking trach valve, or, oh, today, their O2 sats were in the 70s, even, when we increased how much O2 they're getting. So, you may not get anything out of them today. So, really collaborate with your respiratory therapist and your RN. Your docs are typically, other than the pulmonologist, are typically clueless about this whole process, and typically are going to require a lot of education. They're not going to understand why are they even requesting speech therapy on this patient. And so you have to explain to them what your role is. We help establish a line of communication for this patient, probably nonverbal. We're going to be involved in helping wean them off of the ventilator, and my last pitch, my ace card is the pulmonologist requested it. Because a lot of times, even though the primary care physician is basically clueless about what's going on, they sometimes, for insurance purposes, still have to be the one to issue approval for services to establish medical necessity. So even though the pulmonologist, who is really the primary physician caring for the patient, may be saying we need to do X, Y, and Z, they may still have to, depending on the insurance, get clearance from the primary care physician to do that. Scary, very scary, but that's the way some of them work. And so I've just resorted to that. Sometimes when I have a doc who I can tell is clueless, I'll just say, well, the pulmonologist is requesting it, and I'm just here to comply. And as soon as you say the pulmonologist, they typically agree to anything. Anyway, you can tell I've worked with physicians long enough that the MD behind their name garners no automatic respect or kowtowing from me. And we'll get to that point too. You learn that there are lots of other initials after people's names that deserve a lot more respect than the MD. So typically what's going to happen in the acute care process is you get a referral and you're going to basically do a pre-screen. You're going to look at the chart, and if you're seeing that they're verbal, you know there's not going to be any AAC needs. If it says that they're non-responsive except to noxious stimuli, meaning like I can go up to them and I can dig my knuckles into their breastbone and try that sometime when you're bored, it hurts like hell. And if that isn't enough to arouse a patient, then obviously they're not ready. So we're going to watch them to see when their condition changes. But if we find that they're responsive but not verbal, then we know AAC is going to be appropriate. Now we may find that they are responsive and verbal, and they may need our services for other things like aphasia or dysarthria or cognitive rehab or whatever. But at least we know AAC isn't going to be the issue. If they are responsive but nonverbal, then we want to know how accurate is their yes-no response. Do they have one? And how accurate is it? Do they have the ability to focus and attend for a sustained period of time? Basically, in the acute care setting, if you cannot get the patient to attend to you for more than 8 minutes, you can't bill for that interaction anyway. So you want to know, can I get at least 10, 15 minutes? And a lot of times in the hospital setting, you're going to have multiple short visits with a patient to get through your entire treatment plan. I have patients where I might go in and do 3 10-minute sessions with them just to get half an hour's worth of treatment. That's okay. Call that a split treatment. It's not 3 separate treatments. It's considered one split treatment. Don't worry about that stuff. It's probably all going to change in January anyway, because they're going to be changing how we bill for things. So I haven't even heard rumors about how it's going to change. So just that it is. I think they're still trying to figure it out. So that's just based on track records. But they have to be able to attend. And they should be able to follow simple directions. So let me ask you this. Let's say I do the pre-screening, I advance to the screening, and they're attentive, at least they appear to be, but they're unable to follow directions and they don't have a consistent yes-no response. Do I write in there too bad, too sad, patient is not appropriate, or what do I do? I'm going to work on establishing a yes-no response and improving their ability to follow directions. I'm actually going to be a speech therapist and work on their language so that I can hopefully get them to that point where they can. That makes sense? So you're actually going to be doing kind of a dual assessment throughout this process. And which way you decide to go in terms of AAC or not could change during this ongoing diagnostic therapy, where you're basically assessing the patient while providing intervention simultaneously. Okay? So when you do your assessment, you're going to categorize the patient after you complete it into one of 2 categories. Those with good oral control and those with not so good oral control. If they have good oral control, you need to determine, can they get vocalization if we get them air supply? Are they nonverbal because of the trach, basically, or the If they can be vocal, then the first thing that we might want to try is a cuffed trach, if they don't already have one, and can they tolerate deflation of that cuff? So what happens is you have this trach tube, and it's laying in their trachea, okay? And all around it is this balloon, okay? That's called a cuff. And so what happens is as air comes up from the lungs, it can't get around and go up into the oral cavity. It's all shunted in and out through this trach tube, okay? Well, if we can deflate that cuff so that air is coming in and out of here, but it's also going up through the airway, we may be able to get a weak voice. Unfortunately, a lot of patients either can't tolerate cuff deflation, or they certainly can't tolerate it for extended periods of time. So that's when we work with the respiratory therapist on increasing their endurance for deflation of the cuff, because at least then, for short periods of time, they can vocalize. But maybe they are unable to tolerate deflation of the cuff, but maybe we can give them what's called a fenestrated trach, which will allow, when they kind of push air like you would, because you're just breathing in and out, the volume, the pressure is low, but when you speak, you increase the airflow. A fenestrated trach will actually allow, it has like little openings in it that will purge open when there's increased pressure. That allows then some of that air to escape. But as they're breathing, they're only breathing in through the trach. So it's sort of like a quasi-deflation, but it's through these little valves as opposed to actually deflating the cuff. Oh, here's a rule too. So you have a patient that has cuff trach. So there's a little opening on the end of it where basically you take a syringe and you insert the syringe into the end of it. You want to try cuff deflation, so you pull out on the plunger, leave it alone. Okay? Don't remove it, leave it dangling. Why? So when you're done, you just push the same amount of air back in. Because you don't want to be the speech therapist that undid it, then when you went to put it back in, you also had already hit the plunger, so you had to guesstimate, and guess what? You just blew through their trachea. You don't want to be the speech therapist that did that. So if you deflate their cuff with a syringe, leave the syringe attached and the plunger deployed. Or if you feel that you must remove it, that's fine, but leave the plunger deployed so that when you reconnect it, you are putting back in exactly the same amount of air that you removed. The surefire way to see that the pulmonologist has you banned from the unit and refuses to make referrals even for kids with an artic problem to you ever again. So don't do that. Remember that, Dr. Scarborough will drill it into your heads if you do graduate studies here, but I want you to have heard it now, because then it won't be such a news flash. You don't want to have to guesstimate how much air pressure that person had in there. That position matters. One way to be sure of that. Okay? So, maybe they can tolerate, maybe they don't have a cuffed trach, or a fenestrated trach, but can they tolerate finger occlusion? I hate finger occlusion. Why? You know where my finger's been? Do you know where your patient's finger has been? So that whatever's on there is going directly into their lungs. Mr. Smith is a little bit cognitively off because he had a fall off of a ladder in his basement, and so now he's got a mild brain injury, and he's been playing in his feces all morning. And they can't put him in a shower to give him a real shower, so how clean do you think his hands might be? I just give them a nice nod, greeting. If they're Asian, like that because they're not into the handshake. Cheryl, I mean no offense, and I do. But seriously, because you don't know. And what's another rule if you're dealing with a trach patient? Where do you want to stand? Off to the side. You don't want to be in the line of fire. You do not want to take a direct hit, particularly to the face area of anything that they could be projecting through that trach. I speak from experience. And if you are, please pray that you're in a hospital that you get to wear scrubs, because there's nothing worse than being in a hospital that requires, and this is what I don't get, PT and OT are allowed to wear scrubs, the respiratory therapists are allowed to wear scrubs, but the speech pathologists have to wear business attire. I have to wear a shirt with a collar and a tie every freaking day. So guess what I did? I had a scrub top that when I walked into the ICU, went on over the top of my boobs because I liked my ties to be my fashion statement, my fashion accessory, and I lost way too many ties to, because once you get a lumber on your tie, that's not going to come out. Or at least not to the point where I was comfortable putting it around my neck and close to my face again. So anyway, always stand to the side. So you're learning so much valuable real world stuff. Maybe finger, and see, my feeling is if they can tolerate a finger occlusion. Now I'll take my gloved finger and try it before I'll let them. But if they can't, then I want to go to a passing mirror valve or a cortex valve. Those are talking trach valves, so you can actually exchange the tip that's on the outside. And what happens is with a passing mirror valve, it has a flange. So when they're breathing, it pulls open and allows the air in. And when they're breathing out, they can do that. But if they again increase the force because they're trying to talk, that flange closes, and it allows the air to then come up through the trach. So if they can finger occlude, I want to get them either capped, let's put a little cap on it and see how long they can tolerate being capped. And if they can't, or if they don't want, the pulmonologist isn't ready for that yet, then I'll try to get an order for a passing mirror. Particularly if we think that they might be a long-term trach, passing mirror valve is a very good option. Okay. If they cannot get vocalization because of obstruction of the airway, then but they have good oral control, then we'll try an electrolarynx, which is what we typically will use with someone who's had a laryngectomy. So there are two types. There's one that's called a Cooper/Rand. Cooper-Rand. Its names. And it looks sort of like, it's like about the size of an iPod Touch or a slightly smaller iPhone, and it has a cord that connects to a little, not the size of a Mento, you know what Mentos are, vibrating lead that's attached to what looks like a straw, and the person puts that in their mouth, and then they press a button on the vibrating reed part, and it produces that sound so that they can articulate, and it produces the voice through vibration in the oral cavity. I prefer those. You can do the traditional neck type of an electrolarynx, which you may have seen. It kind of almost looks like an old-fashioned electric shaver, and the person puts it there. I don't feel like you get nearly as good of a loudness factor from that, because typically you've got other machines and things going on, and you're going through a lot of tissue. But the person who's had a laryngectomy, they've removed a lot of tissue in the neck. So you can get a pretty good vibration. It's not having to travel through as much dense tissue. Whereas with someone who's completely intact using the Cooper Rand, it puts the sound right here in their mouth so that it's personal preference. Your hospital may say, too bad, so sad, you gotta use the old-fashioned neck style. But you can also train them to then do it on the cheek with one of those old ones. So, but I prefer the Cooper Rand. So that's if you've got someone with good oral control, but they're trained. If you have someone that has poor oral control, then you want to know, is handwriting an option? And if it is, give them a pen and a source of paper, and your AAC assessment is done. And your intervention is in place. I did have a case though where the patient was able to do that, but the spouse and the family members were unable to read. So we were able to use pen and paper for communication amongst the staff and the patient, and come up with an alternative for communicating with the family. What do you think we did? What did we do to facilitate communication with them? Since they can't read, it's writing. Again, pictures work, and just a pointing communication work. Just a very basic communication pictures. And sometimes there was someone available, staff member, the patient could write down what they were saying, and someone could read it to the family. They often wanted, go get the speech therapist. I'm like, it's not cost effective to have someone with a master's degree who can be working with another patient and actually bringing income into the Stanton hospital to serve as a translator for the patient who's writing and has an illiterate family. Had to break them of that cycle real quick. But the first 3 times they called, I heard the page overhead, and I ignored it because I was like, well, there are 3 other speech therapists in the hospital right now, and I'm not assigned to that unit today. And then my pager, this was back in the day before cell phones were as commonplace, and then my pager would go off, and I would look at it, and it would have the extension --911. Call now. We're serious.
If you had a similar situation, but nowadays when a lot of people have smartphones, with their free applications, and if they do have a smartphone that can have the application, could you have them write in and have it speak out loud instead?
It would depend on, because some of the ICU units have equipment where it can interfere with the monitors and things like that, and so they don't allow cell phones or tablets, anything that's getting any kind of a wireless signal in there. If I'm in a unit where they would allow that, absolutely, that'd be awesome. But if not, then then it's not an option. So just always check before you would go that route. Nowadays, most technology is pretty medically safe, and so more and more hospitals are not banning you from having your cell phones. I think because they've shifted the way band, the frequency band that a lot of that equipment is operating on, and so it's not vital communication. Whereas before there was an overlap. So, anyway, if writing's not an option, can they point? If so, then some sort of a direct selection communication board, like a temporary picture board, something like that. If not, then you have to look for some other type of motor response that's reliable, and you're probably going to want to try some sort of partner-assisted scheme. Okay. This is definitely a time. Now keep in mind, in the acute care setting, whether it's the ICU or not, you're often going to be dealing with people who have other medical conditions going on. So they might be aphasic. You got to deal with the aphasia. They might have a brain injury. You got to deal with the cognitive issues. So this sounds all nice and tidy. So just be prepared. You're going to have to be thinking on your feet the whole time. What if and what about? But that is also why a lot of clinicians love the hospital setting, because it's constantly challenging you. And when people ask you what you do, you tell them, they realize, oh, we're not talking about sitting across from a little kid who can't say his S's. No, I'm actually helping get people off of their ventilator. I'm actually helping wean people from a feeding tube so that they can actually eat again. Suddenly your stature in their eyes rises a little bit. So people still think, oh, you're Joseph's speech therapist. Because in most people's eyes, we are not even in the same room with OTs and PTs even. They have a lot. And the other thing is respiratory therapists are like us. People are like, oh, you're a respiratory therapist? They have absolutely, really no clue what respiratory therapists really do. And so absolutely no respect. And quite frankly, if you count recreation therapy, which is legitimate, and music therapy, then we have music, recreation, respiratory, speech, OT, and PT as the main therapies. Well, music and recreation therapy, people totally poo-poo. And then it's us and respiratory, and then it's the OTs and PTs in terms of, until they really realize what it is that we do. Because that OT's not going to get that patient weaned off the ventilator. That PT's not going to get that patient eating again. I guarantee it. So, in the patient and the family's eyes, we're the good guys. The OTs and the PTs, they call them occupational and physical terrorists, because usually what they do is, they really do. But what we do, we restore quality of life. Because if you ask a patient, would you rather be able to get up and walk around, or would you rather be able to eat your breakfast? They're going to tell you to eat their breakfast. If you say, are you going to want to be able to stand at your kitchen sink for 20 minutes and wash a load of dishes, or are you going to want to be able to talk without a tube in your neck? They're going to tell you they'd rather talk without the tube in their neck. So we're all about quality of life. That's my way of thinking. So your role in the acute care setting, in addition to your direct patient care, which takes up a lot of your time, is that you're going to be training people about what we do and how they can best communicate with our patients. And that's going to be obviously the patient themselves. They need to know what their options are. And hopefully they can participate in the decision-making process. Obviously the healthcare team needs to understand what their communication method is, how it works, how we're going to do it, and then the family and friends. So they're all very, very important, and that's going to take up a significant portion of our time. So after you've done your initial assessment, though, your work is not done. You're going to be a lot of times, you're going to be working with them on an ongoing basis because, like I said, we may be trying to wean them from the trach or from the vent. We may be dealing with other communication issues. We may be dealing with a swallowing impairment that's going on at the same time. So typically, you're not in one and done. And even if there are no other issues, you're not going to be one and done. You're going to go back and you're going to reassess and make sure that whatever your method that you suggested is still appropriate. Because maybe the patient was nonverbal, non-responsive. Well, 2 days later, they may be more responsive and it may be appropriate. So you want to keep following up. Because their status might have changed, maybe their communication needs have changed, or maybe they've gotten some sort of return of function. Maybe a family member who can read is now, in from out of town and can serve as the translator. So you want to keep going back, especially if your first attempt was not very successful. Maybe you really, for any number of reasons or combination of reasons, you may not have really come up with what you're satisfied is the ideal solution for the patient. Well then, don't give up. Go back and try something different. Let's see. Okay? So remember my rule. Once is never enough. Think of your work in the ICU as a bag of Lay's potato chips. Nobody can get by with just one. Okay? And why this is important. I put this in there. I'm going to just tell you the story. There were a couple of speech pathologists, and they were working with a spinal cord injury patient. And he had lots of medical complications. He was trached and ventilator dependent, but he was able to mouth words. And he kept saying what the care team was interpreting as kill me. And so the patient's family, and they knew that he had said in passing that he never wanted to be hooked up to machines or anything. And so the family started discussing taking him off of the ventilator and just letting nature run its course. But the speech pathologist said, hey, why don't we try him with the speaking trach valve? Because maybe he can tell us more about his thoughts and what he really wants. And so they did, and they fit him. And what he was telling them and what they could not understand was that his shoulder was killing him. And because his injury was significant enough, they didn't really pay attention much to the fact that he also had a broken and dislocated shoulder. And so here, this family was considering ceasing his care and letting him go because he was saying what they thought was kill me, when in reality he was trying to tell them that he was having a lot of pain and his shoulder was killing him. That's why speech pathologists are important. That's why AAC is important. That's why I feel passive airway valves are legitimately included in your arsenal of AAC. Yeah, that's my opinion. Questions? I think that the ICU in the acute care setting is one of the most fun settings. I loved it. That was probably, other than what I'm doing now, where I get to see patients in a clinical setting and work with you guys, that was probably the most fun that I ever had, was in the hospital. At various stages, because rehab was really fun as well. But you're just, every day is different. Every day is a challenge, and your day moves by so quickly. When you're in acute care and in the ICU, you get paged down to the ER to do a swallowing screening on a patient that they think has just had a stroke, and I would be, out on the floor, and before I knew it, it was 1 o'clock in the afternoon, and I hadn't even stopped to pee. And I've been there since 7:30 that morning. And that's the other nice thing. Normally, as a speech pathologist, is you can work with patients at breakfast on their swallowing. You start the day at 7 and be done, or 7:30 and be done by 3 or 3:30. So you still have. It's a great setting. That's why a lot of people like work in that setting. That's why it's often challenging to find positions in that setting unless you're willing to go to a more rural or underserved area. But I could tell you a dozen stories that maybe are not the life and death like this, but the impact that you can have on people's lives. The lady that started in rehab after her stroke was on a feeding tube, and about 7 or 8 months later, I was out to dinner with my parents visiting, and she and her husband came up to our table, and she told my parents that she was having a steak dinner with her husband celebrating their 60th wedding anniversary, and it was all because of what I did with her, that several months ago she couldn't eat anything, she was on a feeding tube. Believe me, there's nothing that compares to how that makes you feel to know that you had that kind of an impact on someone's life. So, and when you can give the person the ability to say what's really on their mind, particularly if everyone else is thinking they're saying something totally different, there's no dollar value you can put on how great that is. So you guys are really, I think, I've been with you guys since as long as I've been here, and I'm really excited. I think there's a lot of challenges potentially ahead with reimbursement, but they're never not going to. There's always going to be a way to pay for our services because we play such a critical role, and I'm excited that you guys are right there, getting ready to see that next step. Because I probably can't tell. I love being a clinician. I absolutely love it, and I don't regret for a minute. And it's stuff like this that you're like, I really make a difference in people's lives. And you'll be too.
Yeah. So I know we're in a class and courses about all these in grad school, but unless we're placed in these kind of settings, are we actually going to get to learn them?
Yeah, because in like here at Miami, in the fall of your first year, you're here. You're just here. In the spring, you're typically here and maybe one other place part-time. And you typically will do stuff at the Knowles with Dr. Noel Porter. Then in the summer, you do your medical placement. And so the entire summer, for 10 weeks, you're in some sort of medical placement. So you will probably get, you will get experience in a lot of these different areas. Some of the experiences are going to be better than others. I love it when I know that students are going to an acute care hospital because they're going to get a little bit of everything. Some people specifically request a rehab hospital. Some people specifically request a skilled nursing facility, and that's fine, especially if they think that that's what they might want to do. But I think getting just a general, acute care, general medical speech pathology placement is much better because you're going to get exposure to a lot of different things. The only drawback is, but then some acute care hospitals have like their own in-house rehab or they have their own in-house skilled nursing unit. So you may get to follow the patient for a longer period of time. Because in acute care, it's get them in, get them stable, get them the hell out. Because the way that reimbursement works is that a person is admitted to the hospital with a specific diagnosis, and those diagnoses are divided into related groupings. So COPD, which is chronic obstructive pulmonary disease, pneumonia, reactive airway disease, some other, those are all going to be in one grouping. And then orthopedic things like knee replacement, hip replacement are going to be in another related group. And stroke and brain injury are going to be in another. So they call these diagnostically related groupings, DRGs. Based on which DRG you're assigned to when you come into the hospital, most insurances pay a flat rate to the hospital for your entire care, for your entire length of stay. So, the longer that you're there, and the more services that you get, the more of that chunk of money gets eaten away. And it doesn't necessarily take a whole lot before the hospital's in the hole, because they're providing more care than what that's costing them more than what they actually have paid. So the general rule of thumb is get them in, get them stable, get them on, because then the hospital has a better chance of breaking even at least, if not even making a little bit on a person's care. So we are considered in the inpatient side the cost center, meaning we're costing them insurance money. But if by bringing us in, we can get the person out quicker, it's, the pros and cons, the benefits outweigh. But then once they move into rehab or they move into skilled nursing, then we're a profit center because they can actually bill for those services and get paid more the more we're involved. So what's unfortunate is if you only get the acute care side and you don't get anything else, you never get to see a whole lot of progress with the patients. Because as soon as they start showing progress and they're stable, they're out. Whereas if you're in a hospital that has multi-levels of care, chances are you're going to get to follow that patient over time and see some progress. So.
What about in those life and death situations? Like, I know like supervisor, like with Sue and Cheryl here, like
Yeah, we pull back to the point where we're only doing 25 to 50% supervision. Because that's all. In the medical setting.
Are there more involved?
Oh, yeah.
I'm scared. Like,
Yeah. Now, if we're dealing with a stroke patient that we're doing dysarthria therapy with or aphasia therapy with, I'm probably only going to do just like we would do here because it's not necessarily like that. But if you're in the ICU, the farthest I'm going to be is in the room next door or at the nurse's desk watching your every move. I mean, I wouldn't send, a student into the ICU on their own. And if you have a supervisor who does, then now, if it's a patient that's in the ICU because they're on a ventilator but they're pretty stable and then I might say, go in and let's do some breathing exercises with them. Let's, concentrate. Let's time them. Let's watch them. I'm not going to make it as worried because I've already shown you. Okay, if I go 2 sacks drop below this level, this is where you see that. Then, you better adequately supervise for someone who does it. It's fun. It really is. So, and then they're like, give me a group of kids in a school any day. I much prefer that. And there's nothing wrong with that. And that's the beauty of our field. Is you can do what you want. Every day is going to be other questions. AAC looks very different in the hospital and in the ICU than it does like in a school setting or just in a regular clinical setting like we might have with some of the people who see the video with patients like that. It's very, very different. And downplaying the impact that has, but we're potentially a link between life and death. Life and death decisions for our kids. Moving in from life support because body's saying I don't need it. Back body was saying my shoulder's killing me. Yeah.
I just had an unrelated question about the recipe project.
Uh-huh.
It says in the instructions to do a mini communication board including steps for preparation, and then it says also do effects. Like, are you getting the recipe?
Well, what I'm saying is make picture, make a step-by-step picture process of ingredients and how you would, so that, and all pictures should be, so that you can say, okay, for your first ingredient, 1 cup of oil. So it might show a measuring cup. And then,
So just like
yeah,
for like
so that you can,
measurements, like
so that,
different
so
X marks.
it's sort of like, so that you can walk through what are the steps, what do you do? Oven, 350, so basically, how would you tell someone through pictures how to make the recipe?